Welcome to Venture in the South. These are the stories of innovation and success in the southern U.S. that make money, have fun, and do good.
Welcome back to Venture in the South, a podcast about angel investing and startups in the southeastern United States. On this week's episode, I'm your host, Paul, and I'm here with Dr. Dave Miller, the CEO of MPath Health in Winston-Salem, North Carolina, to introduce listeners to what MPath does and talk a little bit about starting a healthcare technology startup in the Southeast. So, Dave, welcome to the show.
Thank you. Wonderful to be here.
We like to make this fairly painless start for everybody. So can you give us a quick intro to your background and what brought you to being CEO of MPath Health?
Yeah, happy to. So I'm an internal medicine physician by training, went to medical school at the University of North Carolina at Chapel Hill. I bounced up to Dartmouth where I did my internal medicine residency training and then stayed up there an additional year on their faculty as a chief resident before joining the faculty at Wake Forest University School of Medicine. When I came to Wake, I never thought I would be an entrepreneur. I wanted to help improve people's health, help them receive preventive services that would extend their life, improve their quality of life. But what happened for me as I started my practice at Wake is I rapidly became frustrated at how medicine was decades behind the rest of the world in embracing technology to give individuals more digital self-service and more control over their own care. And I found myself wondering, why is the travel industry, the banking industry giving people amazing tools to manage their needs? And yet in medicine, we're stuck 30 years in the past where to do anything, you have to schedule an appointment with somebody wearing a white coat like me to get anything done. And so this started me on a 20-year journey at Wake Forest, developing, testing, implementing different digital solutions to see if we could give people some key tools to help them receive the care that they need. This was work that was funded by the National Cancer Institute. We had several million in grants from the NCI. And ultimately, we ended up developing our platform we call MPath, which identifies individuals who are overdue for a cancer screening test, educates them about their options, motivates them to take action, and then lets them request screening directly through our platform, all without setting foot in the doctor's office. We showed in several clinical trials that we published in the peer-reviewed medical literature that we were doubling cancer screening rates. And at this point, I started to get some emails from other health systems saying, hey, we read your papers in Annals of Internal Medicine and these other journals. This looks really interesting. Where can we buy it? How can we get it? And that is the time when I realized if we don't commercialize this, if we don't spin this out of Wake Forest, it ends up dying on my academic shelf. And so, really, to achieve the maximum impact from what we had worked so hard to create, we realized that entrepreneurship and forming a startup is what was needed to get the program in front of patients nationwide to impact care.
Okay, got it. Well, that's not an easy transition, so we'll talk about how you actually did that. But just for now on the platform itself, so walk us through how the platform identifies who needs it, and then the educational content, and then the scheduling part. How do each of those pieces work?
Sure, happy to. And let's just take lung cancer screening as a use case, because lung cancer screening is one of the newest screening tests that have been recommended by experts nationally. The problem with lung cancer screening, though, is that fewer than 20% of high risk Americans who qualify for this screening test actually receive it. And this is kind of crazy when you think about it, because lung cancer is the leading cause of cancer death in the United States. We know if you wait until symptoms to develop, before you get diagnosed, unfortunately, there isn't a lot of curative treatment we can do at that point. However, several studies have shown that if you screen people, well over half of people who have lung cancer diagnosed by screening have it diagnosed when it's really small, potentially curable, dramatically extending life. The challenge with lung cancer screening, though, is unlike other screening tests where we just say, oh, you're 50 years old, it's time to start this type of screening. With lung cancer screening, it depends on your age, depends on how much you've smoked, it depends on when you quit smoking, and a few other factors. So, how our software works is we start by giving a query to our healthcare system partners who are using MPath, and we say, run this query on your electronic health record data, and let's identify everyone who might meet criteria for lung screening. We don't know 100%. Some won't, but many will. And let's reach out to those individuals with an automated text message letting them know there's this new life-saving screening test for lung cancer. They might qualify, and inviting them to click here to learn more. Once that individual then clicks here, it takes them to our MPath web app that runs up in the cloud, automatically starts on their own device. They don't have to download or install any software. And MPath is going to ask questions and use algorithms to first verify that they are eligible for lung cancer screening. And then it shows them a brief animated video we produce to both educate them about lung screening, but also uses principles of behavioral science to motivate them to take action and get screened. And then the program ends by letting them request screening directly through the program. So, contrary to traditional care methods, where to get screened for lung cancer, you have to see your primary care doctor. In the midst of managing your diabetes, your high blood pressure, the primary care doctor has to pause and remember, like, oh, you used to smoke in the past. Maybe lung screening would be beneficial for you. And then take that history, then explain everything. Our software is doing it automatically, independent of a clinical visit, letting you get that screening arranged without the need to come in and see a clinician.
Okay, got it. And so what does that change the rates of compliance from and to, just in ballpark terms?
Sure, sure. So we just wrapped up a large randomized control trial where we enrolled a few thousand patients from across North Carolina, two major health systems in North Carolina. We presented the results of this trial at CHEST 2024. That's the largest medical meeting of pulmonary physicians in the world. And we showed that we increased lung cancer screening rates by about 50% compared to a control group. We believe that 50% increase is actually relatively conservative because in our control group, we told everyone in the control group, you qualify for lung cancer screening. It saves lives. Go talk to your doctor if you're interested. So that wasn't a real control group. That's a
Yeah,
pretty heavy marketing campaign.
yeah, okay, and it still increases the rate by 50%, so that's interesting. How you said, that you use principles of behavioral science to drive that rate, so maybe without sharing too much secret sauce, what are you doing to get people to schedule that appointment?
Great question. So, commonly if you aren't on the front lines of delivering healthcare, sometimes increasing cancer screening seems like it should be so easy, particularly if you're someone who is really motivated to maintain your health. So, for example, many people assume that the only thing you have to do to increase cancer screening rates is to tell somebody, you're 45 and that's when we start calling cancer screening, go get a colonoscopy. Or, oh, you've smoked so much, you should go get screened for lung cancer. But what you find in actual practice is that many people have legitimate fears and concerns about cancer screening tests. Beyond just knowledge barriers of not understanding that cancer screening can save lives by finding cancer early, some people are afraid that tests might be painful, they might be embarrassing. Some people are afraid to receive bad news. I've heard them say, I don't want to be screened because if somebody told me I had cancer, I couldn't handle it. It would kill me just knowing I have cancer, instead of understanding that that's the goal. We find the cancer early when we can easily treat it. So, the behavioral science principles we weave in there are based on a lot of different health belief models, behavior change models that really seek to identify why people are resistant to take steps that would be beneficial to their health, and then help nudge them and motivate them to overcome those concerns and take action.
Okay, got it. I can see why that would be in the interest of the patient. Why is it in the interest of the health systems for them to embark on this
Sure.
technology?
So, health systems, by nature, people who run health systems are human beings. We all want to do what's right for people. We enjoy helping people live more full lives, longer lives. But my friends who are in the C-suite always remind me that, Dave, we want to take great care of people, but if it doesn't generate a margin and we go out of business, we don't have a mission and we don't help anybody. Fortunately, with what we're doing with Empath, it's the right thing to do for patients, but it also is the right thing to do financially for health systems. Health systems today operate primarily in two different worlds. You're either in the more traditional fee for service model where you're being reimbursed for the services you perform, or you're in this new value based care world where you are reimbursed partly based on the quality of care you deliver. And fortunately for us, Empath returns a great return on investment for health systems in both of those worlds. So, in the fee for service world, it makes sense to use Empath because the more people you screen, the more revenue you generate from screening. But more importantly, you generate additional revenue from downstream care. You decrease leakage of your patients to other health systems because if your patient isn't being screened in your health system and they end up getting screened in someone else's health system, that's where they're going to get treated for their cancer. Then in the value-based care world, Medicare is shifting more and more payments over to be incentivized on the quality of care that's delivered. And so by increasing your cancer screening rates, you increase your Medicare star ratings, which translates into better reimbursement from Medicare and other providers under value-based arrangements.
Okay, got it. So I see how you create value for both of those models. How then do you get paid? Do you get paid per successful schedule, or is there another way that you get paid?
We are a software as a subscription platform. Our goal, and we feel very strongly about this, is we want to be a no-brainer for our healthcare partners. We want them to use Empath and say it makes sense for us. It's costing us much less than the margin it's generating. And so how we do that is we charge a very small fee per person who gets uploaded into our system for outreach. And if a health system has any concerns about that payment model, we're always happy to look at other reimbursement strategies or payment strategies for them so that they can be guaranteed that this program is going to bring more revenue into the system than it ever costs to improve cancer screening for their patients.
Okay, got it. I don't mean this question to sound critical, but then why are you in so few health systems so far, given how compelling this sounds?
Yes, I mean it is. It's so what I would say is we have absolutely no problem finding clinicians who are really excited about what we have built and saying this is a no-brainer, we need to do this. I think some of the challenges with implementing any new digital solution or any new product in a health system is severalfold. First, health systems tend to be very large organizations with multiple decision makers, multiple committees. So, one challenge is just navigating your way through that organizational landscape of you might have someone on the front lines who's a clinician saying this is great, I want it, but then there are business units and business offices that you have to go through different layers of approval, and each of those takes time. The other challenge can be that health systems face many competing priorities for their time. And so while we have a proven solution that's going to knock cancer screening out of the park, they may be also focused on reducing hospital readmissions. They may be focused on improving primary care footprint in a given region. And so it's really important that you can show that your solution aligns with their strategic priorities for the year. And then the final piece, and this is one piece where we have a distinct advantage, is there can be concerns around integration with the IT tech stack. Many digital health products bring with them a cost of ownership to the health system because they need to dedicate some personnel to managing those automated connections with the health record, to keeping it up and running. We purposefully are electronic health record agnostic and we run external to the electronic health record. So the technical overhead cost for our customers is minimal.
Okay, got it. Those are good answers. You've also not been doing this for all that long, right? How long have you been outside of the Wake Forest clinical trials environment and been a standalone commercial enterprise?
We spun out of Wake Forest about 3 years ago. And then the first year was spent in transferring the technical stack out of Wake Forest to the company. So we are a young company. We've only been around for about 2 years in commercial use outside of Wake Forest, but we're rapidly growing.
Yeah. So how many health systems have you worked with now over the course of that time?
We have worked with a total of one, two, three, four, five different healthcare systems. We just closed three contracts, additional contracts last month. We have another contract that is approved and just waiting final signature now, and then two more that are coming soon after that. So we're enjoying some recent traction and growth early on in this year.
Good. Congratulations on that.
Thank you.
And that's step one. So then there's the execution side. So how hard is it to actually get up and running and sending out the text messages?
Very easy. This is where one place where we shine because I'm a clinical informaticist as well as an internal medicine physician. Clinical informatics is one of the newer specialties in medicine. Most people haven't heard of it. And mostly what it is it's a piece of paper that proves I'm a computer nerd in addition to, doctor. That's what it is. Uh, but practicing medicine and then also being on the clinical informatics side, and my co-founder, Dr. AJ Durad, who is deep expert in clinical informatics, We saw all the pain points of launching digital health products. So when we engineered this, we purposely made it incredibly technically light on the implementation side. So we can go get up and running with a new customer in less than a week from the time we have all the contracts signed. It's incredibly easy for people to get up and running on our platform.
Okay, got it. Are people using it for just lung cancer screening at this point, or are there other cancer screenings that are equally applicable?
No, we are rapidly moving into other areas. So we have gone to market in the oncology space. Our first module, and MPath is a platform that we can apply to any preventive or chronic care need. We started with colon cancer screening, which is the second leading cause of cancer death in the United States. We showed that we doubled colon cancer screening rates. We then moved into lung cancer screening. We showed we increased lung cancer screening rates by 50%. We are about to release in the next month our module for breast cancer screening. I'm really excited about that module because it not only helps women adhere to routine mammograms, but it also lets women determine if they're at higher risk for breast cancer and might benefit from additional screening beyond mammograms. Most women who are at high risk for breast cancer have no idea. And this is a real tragedy because there are things we can do that could help save that woman's lives. For some women, it might be getting a breast MRI in addition to a mammogram. For some women, it might be genetic counseling and maybe genetic testing to see if they carry a mutation that makes them more susceptible to breast cancer. And our breast screening module actually lets women determine, hey, I'm in this high risk group. I didn't know it. And connects them with a genetic counselor or a high risk breast clinic to talk about what might be best for them. But beyond this, we have a module in the works for fertility preservation for adolescents and young adults with cancer. This gets more on the cancer care side of our platform. I have colleagues working in this area, and the challenge is that if you're an adolescent or young adult and you are recently diagnosed with cancer, you have a pretty limited window to explore options for fertility preservation if that is something that interests you. And so our module helps reach out to those individuals very shortly after the diagnosis and lets them know here are different things that you might want to consider to preserve your fertility if you're interested, and let's help you get those services if you want them. But then we'll be moving into other chronic diseases as well, like diabetes management and prevention, cardiovascular disease prevention.
Okay, got it. It seems like there's a lot of potential applications outside of oncology. How long is the development cycle to move into those? And is that potential even so far as medication compliance and other post discharge kind of compliance questions as well?
Absolutely. So the sky is limitless in terms of what we could move into. So as a young startup company, we're being very strategic in saying, where do we really excel? Where are we strongest? And let's focus on those use cases first, because as the founder and CEO, I can appreciate that there is some danger and perhaps trying to do too much too quickly. And so we're trying to really hone in on the things that where we excel and we bring more value than anybody else in the marketplace right now. Medication adherence, absolutely, we could move in there. I think that will be a little later down the pipeline for us, not because we can't do it, but because we are knocking it out of the park in some other areas and want to strategically focus there first.
Fair enough. There's always a battle between doing too much and doing your best in the things you're expert at. So I
Yeah.
respect that.
Yeah.
Okay. So as a
Oh, I'm sorry. And you had asked how long does it take us to develop a new module? Currently, it takes us about 2 to 3 months to roll out a new module, start to finish. But the more we do, the faster we get at that. And we're re-engineering some things in the platform that will let us roll out modules faster and faster in the future.
for anyone in the audience who's not an oncologist, what could people do to help accelerate your growth?
I appreciate you asking. So, the first is if you know anyone in healthcare systems, particularly strategy officers, clinical innovation officers, people in population health departments, cancer centers, people who are wanting to try to improve the quality of care a health system delivers, or they're particularly interested in cancer care, just connecting us with people in those organizations, we're always happy to give them a very brief overview of here's what we do, here's our clinical trial evidence. And this is something that is fairly rare in the digital health space. As a practicing clinician, I can tell you there are many, many products out there promising to do all kinds of things. Very few have any evidence. I'm not sure that any have over a dozen publications in the peer reviewed literature like we have. And so we really like to go to people and say, here is the rigorous, robust evidence that we have accumulated over the years. What we've learned works, what we learned have learned that doesn't work so well. And just introducing us to people where we can have those conversations.
Okay. Hopefully, we can make a few of those happen for you. And that can be national in scope, I assume at this point. There's no limitation on who you can work with.
Absolutely. And I'll share too that even in Europe, some of the European countries, especially those with national healthcare programs, in some ways they understand and invest in cancer screening even more than in the United States. And so we are looking at the European market as well as a place that we would like to expand in the near future.
One question comes to mind about the challenges of navigating both healthcare data and communication rules, how often you're allowed to spam text people. How do you navigate both of those regulatory environments?
Yes. So this is one point where I think being a general medicine doctor has given me an advantage because most of us in general internal medicine are here because we like everything. We're interested in everything. And so prior to us even forming the MPath company, I stood up our digital communication core for Wake Forest School of Medicine. And I found myself rapidly learning about the Telephone Consumer Protection Act, HIPAA protections, all of these other things. So there are two major regulations that you have to pay attention to. One is the Telephone Consumer Protection Act, which you alluded to. How often can you spam people? And there are laws. Most people act like these laws don't exist because we all get spam texts all the time.
Yeah, all right.
But legally, you have to consent in to receive those texts. Fortunately, most healthcare organizations today, when you sign that little form or the digital pad when you check in to see your doctor, one of those things you are signing is a consent to treatment. And most healthcare organizations have included in their consent to treatment that you're consenting to let them use your cell phone number to communicate with you about your healthcare needs, which covers our use case. However, even if a healthcare system has not done that, the Telephone Consumer Protection Act has a carve out for healthcare. And they have wisely said, you know what? If this is healthcare and this is something you need, and maybe it's, a flu vaccine, or maybe it's time for your mammogram, the government doesn't want to get in the way of you getting critical information that could impact your health. So there is a carve out that says for these types of messages, which Empath delivers, technically doesn't need that consent. For the HIPAA regulations, that gets a little more complicated in terms of how you encrypt your data and store your data. And our technical stack is fully HIPAA compliant. We're SOC 2 Type 2 certified. I'll say we're very proud to have our SOC 2 Type 2 certification this early in our development. From what others have told us, we're a little bit of a standout in how early we have achieved that milestone on our own.
Yeah. Okay. Good. Um, is there a point at which there is too much screening or a saturation of screening, or is that really not a potential concern of a screening company?
So it is very important to us that we help people make the decisions that are best for them. And this kind of layers into our philosophy and our behavioral science approach. We are not out there to tell everybody, oh, lung cancer screening, you absolutely must go out and do this. Instead, we tell people, hey, here's why we think you would want to consider it. It can save your life. But we're also very upfront that screening tests can cause false positives. And if you were to get a false positive, most people, they're just going to be told to come back and get another CAT scan in a year to make sure that that small shadow doesn't change. But there are a small number who are going to go on and get a biopsy. And so you need to know this up front, that a screening test, it can save your life. But there's also the small chance that it could cause you to get a needle put in your chest to prove that you don't have cancer. So I would say that we are appropriately making sure everybody understands how screening can help them, but also the potential downsides. When screening can become too much is, I think, if you're pushing tests that yield many, many more false positives than true positives. And here's a great example. I mentioned breast MRI earlier. And so for your listeners, if you're a listener and you heard about breast MRI, it can save women's lives. That's absolutely true for high risk women and breast cancer early and save their life. However, for average risk women, experts do not recommend getting a breast MRI. And the reason is that for average risk women, a breast MRI is going to find dozens more false positives than it will that early cancer. And if you were to look across a population of 1,000 women, you're going to be putting many, many women through biopsies and invasive procedures they would ever need. So that's an example where I think you could be too aggressive, perhaps with screening. Another example, very popular in the press, you're reading about people who are getting whole body MRIs, whole body CTs. The news articles tend to focus on the potential positive. Oh, you find a cancer early, but there is potential negative. You're finding a lot of things that can lead to a lot of invasive procedures, which may not prolong or improve your quality of life at all. And maybe you would have been better off just not knowing about some of these things.
Yeah. But on balance, the 20% screening rate for people at high risk for lung cancer seems like a massive opportunity to go improve that before anybody starts worrying about the marginal cases.
Absolutely. I think
Yeah.
for lung cancer screening, our less than 20% screening rate is way, way, way too low. I think it's very conceivable that you could have well-informed individuals who would say, you know what, for me, I choose not to be screened for lung cancer, or frankly, colon cancer or breast cancer. For me, I think it makes all the sense in the world. I have family members who are here today because they underwent breast cancer screening. I'm convinced of that. So I'm a big proponent for screening. But I think on a population, if you said, well, your screening rates are at 90%, 95%, then I would say that probably makes sense. I would believe that 1 out of 20 people would say, yeah, I understand, but I just don't want it no matter what. 18%, where we are for lung screening, way too low.
Switching gears for a second, doctors are not known for being entrepreneurs necessarily successfully. How have you coped with that transition from your prior career to your current one?
Yeah, it has been quite a ride, I will say. Again, I'll say that I'm a little unusual for an internal medicine physician. I went to a liberal arts college. I majored in economics and minored in English. The econ background, which is not business, but it gave me an appreciation for efficiency and using scarce resources to obtain the most benefit. The other advantage I had is I was not a physician who was seeing patients in his own practice 5 days a week, private practice model. I was spending well over half of my time leading large research teams or leading some different committees within a very large academic medical center. So I did have some advantage of coming to the startup world with experience leading teams, forming teams, team charters, RACI matrices, things like that. I was always interested in how to lead research teams better. So I found myself, reading books like Lencioni's The Five Dysfunctions of a Team and other books around management styles. But I've learned a heck of a lot more since making this transition. And I will say one thing that has benefited me greatly is being in an accelerator. So when we started the startup, we immediately joined the Winston Starts Accelerator. It's an accelerator here in Winston-Salem, North Carolina, has over 80 different mentors who are business leaders in varied fields who are very generous with giving their time and advice and helping to consult and guide. And so that has been very instrumental to our success.
Great. Yeah, I think you raised money recently after that or alongside those accelerator activities. Do you plan to continue doing that? And what's the ultimate goal for MPath in 5 years from now?
Sure. So we had several benefits starting with MPath. I often say that the National Cancer Institute was our friends and family round, and perhaps even our pre-seed round. We had over 6 million in funding from the NCI, which took us from concept through feasibility testing, pilot testing, all the way to randomized controlled trials. So we launched our startup with a minimum viable product, which we did have to transfer the tech stack. After that, we also received a small business technology transfer grant from the National Cancer Institute to then translate what we had developed at Wake into a commercial product. And that was another $2.4 million grant that we received from the NCI. We did do a initial convertible note raise to help us get off the ground once we were coming out of Wake Forest. That's the round that Venture South participated in. We were very grateful for that support. And we had one follow-up round after that that was led by Oncology Ventures, the nation's only oncology-focused venture firm in the US. And they've been a fantastic partner. When we look to the future, ultimately, our goal is to save as many lives as possible and help people live their fullest lives by helping them receive preventive care services. So we want to see MPath live to achieve that mission. That being said, most startups, the exit is through a strategic acquisition. And so it's our expectation that in the next several years, some company that can add additional value to what we're doing and can grow MPath to even greater impact would kind of enter the picture, and there'd be a strategic acquisition. And in terms of raising additional money, we are committed to raising whatever capital makes sense to let us scale the fastest and reach as many people as quickly as possible.
Got it. Well, congratulations on the progress so far. Thank you for being in the Venture South portfolio and for all the hard work you've put in so far. And good luck with future years of doing that.
Well, thank you, Paul. Really appreciate you having me on the podcast.
Thank you for listening. Visit us at ventureinthesouth.com for a complete list of previous and future shows.